we try to navigate this life, Ed and I were on a podcast once, and we talked about the best way to die. And why I think that's important is that none of us really get through this world alive at the end. So we want to live well, and I think the bottom line is that we want to live kind of at this level and then run, and then we die. And we don't want to run and then die slowly for 40 years. And so that's the difference. And I think that's why this section is important. The next section that we're going to jump into is understanding peripheral artery disease. One of the number one killers of people in this world, in America, is cardiovascular disease, atherosclerosis, that process. And I'm going to have Dr. Stephanie Sheridan come up and talk about let's see if I can get my glasses back on here, recognizing the signs and symptoms of PAD. This is critically important. If we can find and make a diagnosis of PAD, at that point we can start the medical regimen to actually start addressing the patient's issue. So next is Dr. Stephanie Sheridan.
Good morning, y'all. I've been tasked with talking about medical management or signs and symptoms of peripheral artery disease. Kind of getting over a cold, so my voice is a little bit different than it normally is. Wow, that was too easy. So basically, key points I want you guys to take away from this is we can never start a talk without defining what is peripheral artery disease. We want to discuss those risk factors and the signs and symptoms, and I always like to give a few case studies so you can put the pieces of the puzzle together. So what is peripheral artery disease? Peripheral artery disease is narrowing and stiffening of the arteries that decreases the blood flow to your lower extremity. That could be fats, cholesterol, calcium, or fibrous tissue. When we have these blockages, it usually limits that blood flow and causes some symptoms in our patients that we see. We can identify these patients and kind of look at the statistics and say that 200 people worldwide have peripheral artery disease and 20 million in the United States. PAD leads to critical limb ischemia, which can lead to amputation, oftentimes because it's been underdiagnosed and not treated. We know that PAD decreases our mortality rate, and when we look at the cost effectiveness of endovascular repair compared to amputation, we can see that it saves the patient about $15,000 to $20,000 on the year. Risk factors of PAD are advanced age, greater than 50, go figure. Genetics, chronic disease, hypertension, hyperlipidemia, coronary artery disease, and also chronic kidney disease. There is a higher prevalence in African Americans and obese patients, and also we like to hit on that major risk factor of smoking. And we also don't want to just tell our patients, how many cigarettes do you smoke, because when we're talking to our patients, they don't realize that we're talking about using a pipe, we're talking about chewing tobacco, and also vaping. It's a known fact that the liquids that we use for vaping cause stiffness in our arteries, and it's very vital that we hit on those things as well. The main reason I'm up here is to talk about the signs and symptoms of peripheral artery disease. And oftentimes when you all see the patients in your office, they'll come in and say, my legs hurt. And so we kind of want to weigh that and try to figure it out. And you're saying, well, when do they hurt? Well, they hurt when I'm walking. I always like to have a scale, and my favorite scale, if you've been here before, is walking through Walmart. So how far can you make it through Walmart before your legs start to hurt? And usually they'll say, I can make it about 50 or 100 feet. And then I said, what happens? Well, I have to stop And then I rest a little bit. Sometimes I rub my legs, and then I'm able to continue. I usually stop for, say, a minute to 3 minutes, and then I can go. Well, this is claudication, and this is usually the main reason that people come to our office. Often with that claudication, they will have pain in the legs, and some of our patients will have what we call rest pain. That is where they are ischemic to the point where while they're in the office visit, they're sitting there talking to you and they're grimacing because they're in pain. Those patients will sometimes have some ulcerations or some wounds that are very slow to heal. And so we all know that these are symptoms that need to be addressed. They may be ischemic and have hair loss, and they also, the temperature on that foot or the affected limb is usually very cold. So it's important that we look, listen, and feel to our patients. Oftentimes we're talking to them and they still have their shoes on, and this is very rare in our office, but it does happen. And you'll say, well, can I see your toes? And they'll take their shoe off, and then you see gangrene there, and you'll say, well, how long was that like that? Oh, it's been there for 2 weeks. Well, it's important that we are assessing the patient fully and touching them. They often will have weakness and some numbness in the toes, and also pulselessness. If you don't have a Doppler, we usually Doppler our patients, but if you don't have a Doppler, if they're laying flat and they raise their extremity, sometimes you can see the paleness in the foot just right there looking at it, how it changes colors and dependent rubor. And so here's some signs and symptoms that you see when you enter the office. Oftentimes you can see this person has already had an amputation of the great toe that hasn't healed well. There's some rubor, gangrene of the toes, but you can see the other toenails are polished real nicely. And then on this fourth toe, you can see it's really gangrene. It kind of looks like a blister. But we use the Rutherford category often when we're seeing our patients, and you'll see that in our charting when we send them back. We usually take people that have multiple moderate claudication symptoms, Rutherford 3, to surgery if it's lifestyle limiting. Oftentimes it is not. Of course, if they have tissue loss, we know that we need to be doing something to help revascularize these patients. This scale was created by Dr. Robert Rutherford. Case study number 1, this is a 78-year-old female with uncontrollable diabetes. You can see her levels are 150 to 170. She does have high blood pressure, and her symptoms here was right hip pain and calf claudication. And usually patients will claudicate distal to the portion where the lesion is. Hers is right there in her common iliac artery, and you can see that her ABI is about 40% less over there on the right as opposed to the left, and her mobility was about 100 feet. Case study number 2, this gentleman had neuropathy. He's already lost his great toe and has a wound measuring about 1 centimeter by 1.5 centimeter on that second toe. He'd already been placed on Keflex by his primary care, has some claudication symptoms, a little bit of redness on that second toe, no fevers or chills. When we look at his ultrasound, he has disease in both legs, but if you look at the right leg, his distal SFA has about a 50 to 75% lesion, but his ABI, it still looks pretty good. But when we look over here at the left leg, he has a high lesion in his proximal SFA, and then his pedal acceleration times, which we discussed yesterday, show that he has some ischemia there, and that's something for us to go out and help, and also help with that wound that hasn't healed. This lady was 95 years old with rest pain. You can see what the toe looks like, cramping, numbness in the extremities. And here she had a distal pop stenosis of 75%, and her PAT show us that she's critical. She also has tibial disease in her anterior and posterior tibia, so she's only getting about a drop of blood down there to that toe, so it's never going to heal unless we revascularize her. So if you'll look at the picture on your left, you'll see what her artery looked like at the beginning, and if you'll look over towards the right, it shows you what it looked like after we placed the stent in her popliteal and open that up for her. And I'd like to say thank you to all our nurse practitioners and our team.
Good morning, everyone. My name is Carrie. I'm a physician assistant at the Vascular Institute, and I just want to thank Dr. Lassar for asking me to participate today. So we're going to go ahead and jump on in today. We're going to be talking about risk factors of PAD. So let's jump right in. So we have some modifiable and non-modifiable risk factors. Today I'm going to be focusing more on the modifiable risk factors. Those are smoking, diabetes, dyslipidemia, hypertension, obesity, and chronic kidney disease. And we always hear about these and how they contribute to PAD, but really why is that happening? And I think you're going to see a common theme with this. So let's start with smoking. So there are many chemicals produced in cigarette smoke that are responsible for the vascular injury. Nicotine we always hear about, but that's just one of about 7,000 different chemicals that are in place. Cigarette smoke includes volatile organic compounds, and there's aldehydes and non-aldehydes associated with this. Specifically, one of the aldehydes, acrolein, can actually accelerate atherosclerosis through elevated levels of oxidative stress and platelet activation. And to kind of get down into the nitty-gritty of it, smoke exposure causes oxidative stress and endothelial cell dysfunction that reduces nitric oxide bioavailability. All of that can aggregate endothelial leukocyte interaction and induce the production of what we call inflammatory cytokines. This also can impair smooth muscle cell function and amplify platelet activation, which all leads to atherosclerosis. So we have to do better. These are some two facts that I thought were really interesting. Data from a national health interview with the CDC in 2022 showed that about 68% of adult smokers wanted to quit. 53.3% of those made an attempt to quit, but only about 8.8% of those patients were actually able to stop smoking. And we know smoking is a strong predictor of the risk of an unplanned urgent revascularization of the lower extremities following an initial successful treatment. We see this all the time at the Vascular Institute. We go in and revascularize, people continue to smoke. Now we're getting a call that they're having rest pain or gangrene of some sort. So the intention is there by the patients. They do want to stop smoking, and the need is there too from a surgical standpoint. So let's talk about smoking cessation a little bit more. There's a study that showed that there were 3 key steps to prove successful smoking cessation, and it's important to note that you have to do all 3. You can't just choose one as a provider to focus on. You really need to do all 3 in order to get to that, increase that percentage of people who are able to stop smoking. So the first one is having that conversation with your patients. It can be a difficult conversation. Most people know smoking is bad for them. They don't really want to hear it. But it's trying to build that trust with the patient so that you're able to connect with them. Beyond that, nicotine replacement therapies, we all know about gum, patch, lozenge, and so forth, and there are prescription medications as well. And then an active referral for a telephone-based smoking cessation. So Tennessee actually has their own line. It's called Tennessee Quit Line, and you can access that. You can give this a resource to your patients, 1-800-QUIT-NOW. So I encourage you to do all 3. Don't just focus on one about having the conversation. You need to give patients the tools needed other than just the conversation in order for them to really be successful. Diabetes. So this is kind of a detailed scientific slide here, but we're seeing the same things with diabetes. We have platelet aggregation, inflammation, endothelial dysfunction, and vascular smooth muscle cell dysfunction. All of these lead to atherosclerosis, which again leads to PAD. And there was a study that discussed the prevalence of PAD between diabetic and non-diabetic patients. Essentially, glucose intolerance was associated with about a 21% prevalence of an ABI less than 0.9, relative to only about 7% of those with normal glucose tolerance. And then the prevalence of PAD in diabetic patients is really underestimated because of the asymptomatic nature of the condition itself. The patients are not reporting things because they don't feel them. And then they also have that altered pain perception due to neuropathy. So I really encourage you, don't be afraid to touch your patients. You got to put your hands on them. You got to feel for things. You got to look at things, and then probe with your HPI. Ask those probing questions and let them answer. And I thought this was really interesting too. Diabetes was associated with more severe below-the-knee PAD, like in the popliteal, the perineal, the anterior tibial arteries. But for smoking, it's actually more associated with more proximal PAD in the aortoiliofemoral vessels. And we kind of know about diabetes management. I won't spend too much time on this. We have insulin, sulfonylureas, metformin, DPP-4 inhibitors, GLP-1 receptor agonists. These are pretty big right now, and SGLT2 inhibitors. And again, we kind of know these things, but we actually have to take the steps to do this. So we want to encourage exercise, and really this is about forming a habit with the patient. Don't just say, hey, you need to exercise more. Give them some ideas about, hey, let's start walking from here to here. We want to increase that walking daily, to try and form that habit. Choosing healthy food, we got a great rundown this morning for that. Encourage their patient to check your blood sugars at home. You really want to empower them, let them be in control of their condition. And then obviously, if you need any referrals for any macro or microvascular needs. This one's kind of a long slide, so bear with me, but it's some interesting information. So dyslipidemia with a risk factor for PAD. So we know increasing in total cholesterol can lead to PAD. There was a study that followed about 5,000 people aged 28 to 62 for about 38 years. They did complete a claudication questionnaire at 2-year intervals, and there were 381 cases of incident claudication. So the findings here were about every 40 milligram a deciliter increase of total cholesterol was actually associated with a relative risk of 1.2 for claudication. Increasing LDL as well. So another study looking at mean age of about 81 with symptomatic PAD patients. This study, each 1 milligram deciliter increase of LDL was actually associated with a 1.9% increase of PAD. HDL is actually a really important one. It's actually one of the most strongest lipoprotein factors for PAD. A study did show about every 5 milligram decrease in HDL was associated with a 10% increase of PAD. I think that's pretty significant. And then triglycerides, there's kind of conflicting studies on this. Some say that it can be a risk factor and some not so much. Obviously, we have the management of dyslipidemia. I want to focus on statins here. You might have heard Dr. Lassar talk about this yesterday, but statins do have an anti-inflammatory effect, and as we've seen, these risk factors, the main theme here is causing inflammation. So even if someone is borderline, or maybe they haven't reached the point of having dyslipidemia, starting them on a statin can help reduce their risk of PAD in the future, especially with a strong family history. Hypertension, it essentially stresses the inner lining of the blood vessels, which causes damage to the arteries. That leads to plaque buildup, and then obviously plaque buildup leads to atherosclerosis. Essentially, blood pressure just causes a shear stress on the arterial walls and results in endothelial injury and impairment of vasodilation. So that really leads to reduced blood flow and leads to PAD. Management of hypertension, we have all of our hypertension meds here. Once again, I want to encourage blood pressure checks at home, making sure the blood pressure machine is actually functioning well, that's important, and helping control patients' chronic pain and stress. Obesity obviously can lead to increased inflammation in the body, which clogs the arteries and induces slow healing. It's linked to other risk factors that we've already talked about. One of the main things I want to point out here is that CRP and fibrinogen are actually strongly associated with body-wide inflammation and obesity. We see that a lot in obese patients, and there's a lot of studies on that. And so there's actually known factors that lead to this inflammation in obese patients. So again, we got to have that difficult conversation. It's hard to have, but with obese patients, we want to get them involved in the community with exercise programs. You might need to do a nutritionist referral, hormone testing or thyroid testing, and do not be afraid to refer to bariatrics. I've had that conversation a few times, and sometimes that gives patients hope. Chronic kidney disease, essentially CKD can lead to a buildup of uremic toxins in the blood, which damage blood vessels. And CKD is an inflammatory condition. Here we go again. Something that's really interesting too is high phosphate and homocysteine levels. These actually contribute to development of claudication in the legs, and there's lots of studies about homocysteine specifically if you guys look into it. And once again, we're going to touch on those lifestyle changes and helping control other comorbid conditions. And lastly, just to touch on the non-modifiable risk factors, increasing age, especially over 50. When you're over 50 and increasing in age, you have a longer exposure to these risk factors. So, we have that plaque buildup, that buildup of cholesterol, vascular changes. We have an increase of calcium deposition. We have a decrease of collagen and vessel diameter. And then family history. There's actually no clear scientific reason that they found why family history is so strongly correlated, but one study did show that it nearly doubles the odds of you having PAD if someone within your family has PAD. And then race, peripheral artery disease is actually more common in Black communities. It's really primarily thought due to because they have more of a increased risk of having these risk factors in general. And then lastly, just genetic and prothrombic mutations. But that's all I have for you today. Thank you.
Excellent talks.
Hello, my name is Amy Scott. I'm one of the nurse practitioners at the Vascular Institute. These are my objectives. I was going to focus on complications and outcomes and early diagnosis and intervention for PAD, which Stephanie's already talked about. PAD, it is a peripheral artery disease that's chronic, resulting in narrowing of the arteries, especially in the legs. See here, PAD is PAD is a complication are primarily caused by reduced blood flow, which affects, the legs, and it can be overall. Intermittent claudication is one of the early signs of PAD. It's a cramping, fatigue, and pain in the legs. It usually occurs during activity, and the pain is usually below wherever the stenosis is located. The ankle brachial index is what we use. It's a non-invasive test that compares blood pressures in the leg and the arm. You don't want a low number. Low number usually means more severe PAD. 0.9 indicates diagnosis of PAD, and severe PAD is a 0.4. We use the Rutherford scale in our office, and it just helps you gauge the severity of PAD. Starts from asymptomatic, and it goes all the way up to severe limb-threatening cases. Patients usually with stages 1 through 3 experience varying levels of claudication, or stages 4 through 6 reflect critical cases like critical limb ischemia. Critical limb ischemia is one of the most severe forms of PAD, and it corresponds with the Rutherford 4 through 6. Critical limb ischemia involves severe pain at rest. It worsens overnight. Usually they'll have some non-healing wounds on the feet and the toes, and it can advance to gangrene. When it goes that far, they will probably have to do some type of surgical intervention. Treatment challenges: we want to restore blood flow, relieve pain, prevent tissue loss, and prevent amputations. Treatments: you just saw Dr. Qualzo doing the angioplasty and stenting to open up the blocked arteries. If that doesn't work, sometimes they have to go in and do a surgical bypass. And then we also do a lot of wound care to help with healing and prevent infections. Let's see here. Challenges: they are at high risk of reocclusion. Like Dr. Lassar discussed, if they don't change some of their behaviors, it's going to happen again. PAD is lifelong. Once you have it, you have it. Comorbidities: obesity, diabetes, heart disease. There is a high rate of amputation with these patients who have CLI, but we want to help stop that and prevent it. This is a case study, She was a 66-year-old female that came in to one of the hospitals. She had a history of diabetes, hypertension, chronic kidney disease, smoking, and anemia. You can see she has she had severe foot pain, cold limb, discoloration, edema, and you could not Doppler her pulses. So they did testing. She had an occlusion pretty much from the SFA down. They tried several times to open it up. It was unsuccessful. She was not a candidate for a surgical bypass, so she did have to have a left leg above the knee amputation. Let's see here. The amputation rate is about, like I said, about 20%, and we want to really stop that if we can, because the 5-year mortality rate is about 50%. Post-amputation patients have a lot of significant physical disabilities. They are, increased dependency on caregivers, and they have a reduction in quality of life. Prognosis and long-term outcomes. Sometimes the prognosis can be poor without intervention. CLI increases the risk of amputation and mortality, so you want to intervene early. Approximately, like I said, 50% within the 5 years. They have significant disability, often requiring long-term rehabilitation, increased dependency on others, and high risk for depression and anxiety. The key point here is really early intervention and diagnosis is crucial in managing PAD. So, because we want to prevent any type of amputation or limb loss. Thank you.
I'm back again. I'm going to be talking about the treatment and management and lifestyle modifications of PAD. We have gone over what causes PAD. I talked about that initially. Carrie kind of hit on the factors, risk factors that we can change. And this PAD impacts our quality of life associated with cardiovascular disease. The common symptoms we've mentioned multiple times, but we want you to take home that leg pain, claudication, numbness, wounds that are slow to heal. Often we have diagnostic tools such as the ABI, duplex ultrasound, and of course angiography to help treat and diagnose early for better outcomes for our patients. This also involves medical management, which you can see a lot of our patients on antiplatelets, anticoagulants, statins, and controlling their chronic diseases. Surgical options are angioplasty, stenting, and bypass. The goal is to relieve their symptoms and improve blood flow, preventing the progression of disease. Lifestyle modification changes are a dual process. I often talk to my patients and say, I need you to buy into this because we can do the medical part, but they have to make the lifestyle changes or want to make the lifestyle changes necessary. Lifestyle changes within our control. Basically, Carrie hit on that, stopping smoking and exercising regularly, eating a healthy diet came earlier today, and having a primary care that manages their care consistently. Factors outside of our control is, increased aging, African American, and genetics. It's hard to outrun our genes, but we can do our best at trying to make those lifestyle changes that help with that. Quitting smoking is the most crucial point, but your patients have to want to quit smoking, and sometimes that's hard because it's just, it's a habit, and a lot of them, they don't even really smoke the cigarette. You ever see that older mechanic that just puts that cigarette in his mouth and then he talks and he puts it down? And usually it burns out, but they have to want to. And usually after that first conversation with us, they may not want to, But then surgery after surgery, as Dr. Lassar said, if we're not able to have you buy into your care, it's real difficult, to keep persevering. And that's where we get to that point of amputation. But we know that if we reduce PAD and they quit smoking, you can see that they can reduce the lifespan, or increase it, 50%. How do we achieve this? Smoking cessation. And we do a lot of smoking cessation in our office, trying to counsel them and get them on the right medication as well, Wellbutrin with the Nicoderm patch to kind of help. And just usually, I always say take a pack of celery, because sometimes it's just that hand to mouth, correlation that they have. We want them to exercise, and now we see a lot of supervised exercise programs coming up. And this is really important in improving the blood flow to the extremity. I have a lot of patients that work at Volkswagen or Amazon, and they walk 10 to 20,000 steps a day, and they have multiple lesions on their ultrasound, but they've created collateral flow around that area of blockage, and they're not symptomatic, so we don't operate on them. So I usually tell my patients to walk till they have pain, and then I want you to push yourself and walk 20 feet more. And if they continue to do that, they usually will see the benefits of exercise therapy. Of course, we talked this morning about a healthy diet and our dietary patterns. And so we've heard a lot about that. I usually say the 80-20 rule. So if 80% of the time you're eating like you're supposed to, healthy, I say Monday through Friday, then on Saturday and Sunday you should be able to have that meal that you want. At the holidays you should have a slice of pie, just don't eat the whole pie. Importance of controlling comorbidities. It's important for routine monitoring, medication adherence, lifestyle changes to manage these conditions so that we can prevent the progression of PAD. Educating and supporting our PAD patients is vital. Resources, support groups, and of course regular follow-ups with our patients. We just want a collaborative approach with the vascular specialties, cardiovascular, podiatry, our primary care. All of these people are part of that multidisciplinary team that's vital to our patients. So take-home points are basically just to improve the patient's quality of life and reduce the progression of PAD. For more education opportunities, please go to vascularinstituteofchattanooga.com. Thank you.
Great, thank you. Thank you for the great lectures and staying on time. That's always the hard part. So I do have a question for you, and then I want to see if the audience has any questions. But so Stephanie, what's the hardest part of your job? And you can't say the doctors you work with.
So, am I on? So the hardest part of my job is probably seeing the chronic people. I've been with Dr. Lassar for a long time. And so you see that 5-year mortality rate that's up there for our patients for amputation. Because I have a lot of ODs, it's very difficult when they get to that end-stage disease, and sad, especially when for 5 years you've been saying you've got to stop smoking. So that's probably the hardest part, because they say, I never thought he would not be able to open me. And so I think that's where I am now, because I've been with you such a long time. We got a lot of oldies together. And I call them the Lassar onlys, y'all, because they only want to see Dr. Lassar. So anyway, that's the hardest part.
We have a history together. Amy, you are our newest acquisition to VIC. 6 months in, 9 months in, great job on your lecture. What's your hardest part of your job?
Oh, right now, still just learning what I'm doing.
It's a good thing you have a team around you.
Yes. I have a lot of, my references should have been a picture of the doctors and Laura and Ashley Cates and Ashley Elledge. Like, that should have been my references. It's just right now learning what's going on and, you know, really truly getting a grasp and a hold of it.
Carrie, you're in that same boat. What's your hardest part of your job?
I would say smoking cessation in regard to PAD. I had a patient the other day who had a significant occlusion. He had rest pain, flat toe pressures. He was going to need surgery that day. And I tell him all this, you know, his face goes white. I felt like I really made an impact about, you know, we talked about smoking, all of that. I'm going to go set up his surgery. I go outside to go chat with him about the timing, and I catch him smoking outside. So, yes, that would probably be a really hard part, just managing the risk factors like I talked about. And then, what was your other question?
Just your impression.
Oh, yeah. I learn something new every day.
Gotcha.
Yeah,
Gotcha.
from everybody, from my patients, from my colleagues, everybody.
So as a young vascular surgeon 20 years ago coming into this community, I was a baby doctor at that point. And there was a tremendous burden of PAD in this area. And my day would be 4 days of operating and 1 day of clinic, and I would see 50 patients in that day. And for how many primary care in here? How many do primary care every day? 50 patients? That's a lot. That's a lot. That was dictating until midnight to finish up on my notes. And what I felt was that I was basically a plumber. All I did was fix patients and then talk about it and then fix them again and find the next patient to fix. And we really didn't have the vascular medicine component to deal with the 20 minutes it takes to talk to somebody about smoking cessation. At least I didn't in my world. And so that's why we have created this relationship between nurse practitioner, PA, and where we spend that time to talk about it. So it's absolutely critical what you do. You're the other side of the coin. I can fix things. Will Harris, Dr. Quazzo, we can fix things. But you play a very specific role in vascular medicine for these patients. And really the whole medical community, you know, we will do things like we might put somebody on a high-dose statin, and it's because our data shows that that particular patient is going to do better. We don't care about their cholesterol level. Don't care about that. It's an anti-inflammatory effect to protect patients from heart attack, stroke, and different things related to PAD. So we will want to work, you know, together with the medical communities, and I want to thank you, ladies, for answering my questions. Are there any questions from the audience? All right, so this means break time.